In metastatic ER-positive breast cancer, we know that endocrine therapy and the various targeted agents and in pathways that kind of enhance the effectiveness of endocrine therapy can cause prolonged responses that can last for years and years and years. On the other hand, virtually all of these patients and all of these tumors at some point will become resistant to the endocrine approach, and we will see some progression and need to switch therapies. That's just the nature of where we are today. We just do not get cures in the metastatic setting for the most part. So virtually all patients would be expected at some point to have a resistance build up to an endocrine approach. And we've been working on other pathways that can combine with endocrine pathways, adding agents together, such as the cell cycle inhibitors, CDK4/6 inhibitors, such as the PIK3CA inhibitor alpelisib, such as older data from the mTOR inhibitor everolimus. And we're looking at more and more pathways. We've got AKT inhibitors. We had a negative trial of an HDAC inhibitor presented at San Antonio. So we're looking at the right timing of these things, and can hitting a couple of pathways at once prolong the response. Potentially, I mean, the long-term goal is going to be to lock in a response so that there is no relapse and no progression. I think we're increasingly finding that estrogen receptor ESR1 mutations arise in the setting of being on long-term aromatase inhibitors, not uncommonly. And so that's a mechanism of resistance. And there are studies looking at whether the SERDs, the selective estrogen receptor downregulators, like fulvestrant, but increasingly studies looking at oral versions of SERDs, are particularly effective when we find an ESR1 mutation. So lots going on, looking at what are the pathways, what are the changes that are happening at the time that resistance to a first-line or second-line endocrine regimen occurs, and then appropriately adjusting to a new agent that might be more effective there.